2025. Myself, Dr. Praful Maharana, and I was communicating with you in all that WhatsApp group. And first of all, thank you for participating big this time compared to, since we have 2 more minutes. So this time compared to last year AIOC, we got a lot of entries. That's why a lot of confusion. 4 and 5 people's name were missing in that final program. But if your friends are there in that group, please let them know. They can come and they can present in those specific sessions. Like cornea, if your title is missing, please you can present in cornea session. Just one thing, please inform the moderator. I have informed all the moderator that there are few names might be missing, but those people will come. Please do let them present. So you can present, you will be considered for the awards also. Second important thing, this program is not not for competitive purpose, but to improve your learning and how you present a case, right? So there is no definite scoring system or headings as per se. The expert panel will decide who is the best presenter, and second and third. The certificates will be given online. It will be emailed to you, or you can download from the AIOC website, right? So since we just have 1 minute left to start the session, I would like to invite the experts for today's session. Dr. KV Satyamurthy. Sir, you can take your seat there. Sir is from Karnataka, an excellent corneal surgeon and excellent teacher. I just came across him recently, then immediately I invited him, please join us for the PG Capsule program. And Mukesh Kumar Taneja sir, and sir is also running an academic institute. He has resident, he has also vast experience of teaching. So they will be guiding you and they will be scoring you, and I'll of course moderate this session. So since we have 1 more minute left, I think any query you people want to know. And one thing you please remember, the certificate as well as the awards depends on how much you are attending the PG capsule, because this since most of you are postgraduate, not only cornea, you should know each and everything, right? So ensure that you are present here at least in most of the session. Encourage your friends, also learn something. And if you present and you leave, we are not going to consider your name for any best of the paper of the session awards. Okay. So with this, I would like to invite Vaishali. Vaishali, are you there? Our first speaker is Vaishali, followed by Akash Chaudhary. Yeah, Akash, please. Then Anamika Chaudhary. You please be ready for with your PPT. Himanshu. Amrita Vasni. Yeah. You are here. Okay, good. Anyone from PCO team here? Alcott?
Good morning, everyone. I'll be presenting a case of posterior polymorphous corneal dystrophy. This is a follow-up case, and we'll be discussing how the patient presented in the last 3 years after an initial diagnosis 3 years back. So PPCD is a dominantly inherited disorder of the corneal endothelium associated with characteristic endothelial morphologic abnormalities. Signs usually appear in the first or second decade of life. Most have bilateral, non-progressive or asymptomatic disease. 4 variants are described due to the genetic profiling of the disease. Considering the inheritance pattern is common, which is autosomal dominant, and there are 4 genes implicated in the disease, namely OVOL2, COL8A2, ZEB1, and GRHL1. The case in discussion, as described, is a 30-year-old male follow-up case of bilateral PPCD 3 years from the time of initial diagnosis. This is the case that was published in IGO case reports 3 years back, wherein the patient presented with a mild with the rule astigmatism and a slightly raised pachymetry in the right eye. After 3 years, at the age of 30 years, the patient had diminished left eye uncorrected distance visual acuity, worsening of with the rule astigmatism, slight steepening of both the corneas, and slight raise in the central corneal thickness of both the eyes. As you can see here, it is a typical railroad track-like lesion appearing in the right eye, which is oblique and is in temporal paracentral cornea at the decimal membrane endothelial junction. A similar band-like lesion with having parallel scalloped edges is also present in the left eye. It is a horizontal lesion at the same junction of the decimal membrane and endothelium. The central corneal thickness, as measured by ASOCT, is shown here, roughly 563 and 555 microns. Right eye topography was done in the second follow-up visit, wherein the cornea shows a mild bow tie pattern in the anterior axial map, and there is mild with the rule astigmatism with no evidence of keratoconus or ectatic deformation. Similar patterns were observed in the left eye, with slight worsening over the right eye, but still there is no ectatic or keratoconus pattern developing over here. Now, the patient was actually presented to me 3 years back because of slight worsening in the vision, and he was interested and keen to have a refractive surgery performed on him. So, these are the risk assessment factors in planning refractive surgeries in such patients. So, in our case, there were mild visual symptoms, morphological changes sparing the central visual axis, normal corneal topography, open angles, healthy nerves, and thick CCT, which were the protective factors in this case. However, a limitation of this case report is that we were not able to perform or evaluate the endothelial cell density, and the specular microscopy was not done. These are the references for my case, and the clinical implication of discussing this case is that bilateral astigmatism in PPCD is suggestive of developing endothelial lesions. Screening of first degree relatives is a must given its mode of inheritance. A detailed risk assessment is important while planning refractive surgeries in such patients, and there is a variable visual prognosis due to which a clear follow-up, a keen follow-up, and especially specular microscopy should be performed at each visit. Thank you so much.
Thank you so much, Akash, for sticking to the time limit. And any comment from our experts?
No, how did you manage this particular case? Of course,
So we are
vision was
still
quite good.
evaluating the patient. He has been very keen to get a refractive surgery performed, but since the refraction is changing annually and this is a 3-year follow-up, also we are not able to assess whether the endothelium is decompensated or not, hence we are still holding the patient.
Suppose patient comes to you with say drop in vision.
No,
Say
sir.
6 by 36 or 6 by
Initial
6.
diagnosis 3 years back was performed. It was a very routine investigation. The patient was just wanted to share that he has been having complaints of blurring of vision. So we performed a slit lamp examination. As you can see, the topo still doesn't show any characteristic patterns of PPCD. It is still a slit lamp diagnosis, but we are not keen to perform a refractive surgery, keen to plan as of yet.
Thank you,
Thank you
Akash.
so much,
In
sir. Thank
fact,
you,
in
sir.
most cases of PPMD, you may not be required to intervene throughout the life because this disease progresses very slowly, and specular count is somehow surprisingly normal. Morphology is abnormal, but count is normal. Thank you. That was a
Thank you so
wonderful
much, sir. Thank
presentation.
you.
Vaishali, are you there? So Vaishali, please come for your presentation. And the next speaker, if you are ready, the time she finishes, please come to that podium, right? So you present that and come here.
A very good morning to respected judges and my dear friends. I am Dr. Vishali and today I'll be presenting my case on the topic, an interesting case of intrastromal wooden foreign body following trauma in a young female. Ocular trauma is one of the major preventable causes of ocular morbidity and blindness in children. And it may lead to myriad of manifestations like eyelid laceration, conjunctival and corneal foreign bodies, hyphema, iridodialysis, cataract, RD, globe rupture. Hence, it requires immediate intervention. My case, a 5-year-old girl, she presented to me with complaints of pain, redness, swelling, diminution of vision of her left eye post penetrating injury from a wooden stick while playing one day back. This is an image showing her left eye full thickness corneal tear with Siedel's test positive in presence of intrastromal wooden foreign body. Coming to examination, on examination we could not assess her visual acuity and ocular motility because she was not cooperative due to pain. Anterior segment examination, conjunctiva had diffuse chemosis with congestion, pupil was fixed and dilated, cornea had an intrastromal wooden foreign body present between 12 and 6 o'clock hours with full thickness central corneal tear of size approximately 9 into 1.5 mm with surrounding infiltrates and stromal edema. Here is a schematic diagram showing her anterior segment examination. Posterior segment could not be examined due to hazy media. NCCT of the orbit revealed left eye flat AC with iris abutting the cornea. The patient underwent emergency surgery of her left eye with removal of intrastromal wooden foreign body with corneal tear repair with AC wash with intracameral moxie under general anesthesia. Here is an intraoperative photo of the patient showing intrastromal wooden foreign body removal measuring approx 7 into 2 mm. Figure 3 is representing the post-op photo of patient showing removal of foreign body and corneal tear repaired with 10-0 nylon and air bubble in AC. We advised her systemic steroids and antibiotics along with topical steroids and antibiotics in cycloplegic. The culture report was negative for any bacterial or fungal element. She was advised regular follow-ups and regular follow-ups were done. Patient's visual acuity improved to 636 with no complications even after 3 months. Here is an image, 3 months post-op photo of the patient with her left eye with corneal opacity after healing of the tear. So my case was unique in the aspect that due to our rapid response and emergency OT services, we made a rapid diagnosis and operated the patient within 8 hours, leading to a better visual outcome and preventing disastrous sequelae like end-of and corneal blindness. Coming to the clinical implication, traumatic corneal tear is a significant cause of uniocular morbidity and visual impairment. And the interesting part is that most of these cases are preventable. So public awareness and education on ocular trauma prevention are essential, along with timely surgical intervention, which is critical. Thank you so much.
Thank you, Vaishali. Even the statement that prevention is better than cure holds true for such cases. Any comment from our experts?
Which antifungal drug you?
Sir, we did not use any antifungal drug because the culture report came out to be negative.
Negative.
Yes, sir. Yes, sir.
Hypopion? What about hypopion?
So there was no hypopion.
So normally few people know they advocate that even whenever there is a trauma and wooden foreign body is there, you should give prophylactic antifungal. But you are right, if your culture is not showing any organism, there is no point of starting antifungal.
No, I would like to add one point here. Say to know the depth of foreign body entry into the cornea, stroma, better to do anti-segment OCT. At least you know whether you can remove it in the OPD or you can remove it in the...
Yeah, that's a very nice point.
Okay, sir, that we did not do, but we will take care from next time.
Thank you, Vaishali.
Thank you so much,
we move on to third speaker, Dr. Anamika, right? So she will be speaking about a case of CHED. So the title have been, it's not exactly what you sent to us because it would have been difficult for me to accommodate in the program. Okay, so CHED means something unique about CHED.
Good morning, respected judges and all my dear friends present here. Myself, Dr. Anamika Chaudhary, and I'm going to present a case on congenital hereditary endothelial dystrophy. CHED is a bilateral corneal condition characterized by cloudy cornea that may be present from birth or may be infantile in onset. As a consequence of the endothelial dystrophy, the cornea becomes edematous, which leads to a degeneration in the patient vision. Case details: a 15-year-old female from Jharkhand presented to our OPD with complaints of diminished vision in both eyes since childhood. History of presenting illness: my patient experienced blurring of vision since childhood. She went to local practitioners and was managed conservatively. Surgical management was not done. There was no history of pain or redness, no history of worsening of symptoms in the morning hours, no history of trauma or any ocular surgery, no systemic history, no similar family history, a normal vaginal delivery with no forceps injury. General examination and systemic examination were both within the normal limit. Coming to ocular examination, in right eye, the uncorrected visual acuity and the best corrected visual acuity was finger counting at ½ meter, and in the left eye, it was 1 meter. Rest everything was within normal limit. Coming to anterior segment examination, as we can see, there was bilateral, diffuse, grayish, blue ground glass corneal haze extending up to the limbus without leaving any clear zones. Corneal thickness was increased in both the eyes. Additionally, multiple bullae could be seen on the epithelium of right eye. My differential diagnoses are as follows, and my provisional diagnosis is congenital hereditary endothelial dystrophy. Management options in CHED, as we know, are penetrating keratoplasty or posterior lamellar keratoplasty. In this case, we planned for right eye penetrating keratoplasty as the visibility was very low, and in the left eye, DSEC. Investigations were done and were within normal limit. Her right eye PKP was done. This is her intraop photograph. Post-operatively, she was given eye drop moxifloxacin dexamethasone 1 drop 6 times daily, eye drop brimonidine timolol twice daily, eye drop carboxymethyl cellulose, tablet prednisolone started with 40 milligram and tapered accordingly, tablet free ciprofloxacin and others. This is her post-op day 7 photo. Her uncorrected visual acuity was 660, IOP was normal, graph clear with few DM folds, no infiltrates or reactions in the AC, 16 interrupted corneal sutures intact, AC well-formed, pupil NSRL and lens clear. Post-op day 30, her uncorrected visual acuity was 636 and best corrected visual acuity was 612. Rest everything was within normal limit. This is a post-op photo. The patient is still under follow-up and we have planned for her left eye DSEC surgery. What is unique is that CHED is a very rare autosomal recessive disorder. As we all know, what makes it particularly unique is how it manifests. It is severe and the corneal changes do not fluctuate with time, unlike many other eye diseases. Clinical implication: it is very important for an ophthalmologist to diagnose this condition accurately, predict the natural history of the disorder, and do genetic counseling and prompt medical and surgical therapy. Take-home message is that timely and prompt intervention is essential to prevent the development of amblyopia resulting from visual deprivation in these conditions. Thank you so much.
Thank you, Anamika. Just one question. You said in the differential diagnosis, CHED, one differential diagnosis glaucoma. In fact, a lot of time people confuse with congenital glaucoma. So how will you differentiate from congenital glaucoma?
Sir, in congenital glaucoma, we can see ophthalmos, harp, striae, which was not there in this case. The IOP was also normal, which is usually raised in cases of congenital glaucoma.
And one classic feature of CHED, for all of you remember, this is the only corneal disorder where the corneal thickness will go 2 or 3 times more. Okay, that is the classic feature. Always remember that. Whenever you are confused with CHED, with PBK, Fuchs, anything, just measure the corneal thickness. In CHED, it will be around 1500, 1600. That will never be seen in FECD or even pseudophakic corneal edema. Thank you. And any comment from our experts? Okay. So we move on to our next speaker, Dr. Himanshu. So after Himanshu, I think it's Dr. Amrita. Are you there? So you please be ready there, right?
Good morning, everyone. My topic of discussion is Thiel-Van corneal dystrophy, which is a rare corneal dystrophy. Inherited disorder that affects the cornea. It belongs to a group of subepithelial stromal corneal dystrophies and characterized by bilateral progressive changes in the cornea. It typically presents in childhood or early adulthood with symptoms such as recurrent corneal erosion, blurred vision, and increased sensitivity to light. It follows an autosomal dominant inheritance pattern. Coming to our case, a 13-year-old female presented to us with gradual progressive diminution of vision in both eyes with intermittent episode of pain since childhood with a strong family history, with no history of any past systemic illness, and the general physical examination and systemic examination were within normal limit. Coming to ocular examination, the best corrected visual acuity in the right eye was 4/60, in the left eye it was 6/60. The intraocular pressure in the right eye 19 and in the left eye 18 mm of Hg. The eyelid, eye wall, conjunctiva were within normal limit. Coming to the corneal examination, the cornea, we can see the superficial subepithelial honeycomb-like opacities, which is not extending to the limbus, and the rest of the eye wall within normal limit. The ocular investigation suggestive of mild to moderate component of the dry eye. The pre-op investigation on slit lamp examination, we can see the superficial subepithelial honeycomb opacities, which is not extending to the limbus. ASOCT suggestive of sawtooth pattern of hyperreflectivity in Bowman's layer, and confocal scan suggestive of hyperreflective material with homogeneous reflectivity, round edges and dark shadows within the basal epithelium. So based on this, we reach to our differential diagnosis of Rees-Buckler corneal dystrophy, which usually present with confluent irregular geographical like opacities at the level of Bowman's and superficial stroma, which is not present in our case. In Thiel-Van corneal dystrophy, it usually present with reticular subepithelial opacities with limbal sparing, which is present in our case. Granular dystrophies usually present with crumb-like opacities involving subepithelial layers. Lattice dystrophy have refractile glass-like branching lines in subepithelial layers, and macular corneal dystrophies have irregular grayish-white flakes-like opacities at the stromal level with intervening haze, which is also not present in our case. So based on this, we compare our case to Thiel-Wenger corneal dystrophy according to IC3D classification, which shows the superficial subepithelial honeycomb opacities, which is not extending to the limbus. Again, according to Sibelman et al., the ASOCT also suggestive features of the Thiel-Wenger corneal dystrophy. The confocal microscopy, according to the IC3D, suggestive of Thiel-Wenger corneal dystrophy. So based on this, we made our diagnosis of both eye epithelial stromal corneal dystrophy, probably the Thiel-Wenger corneal dystrophy. The patient underwent right eye superficial anterior lamellar keratoplasty under general anesthesia. This is the clinical picture post of day 1. And the ASOCT post of day 1, we can see the regularity of the cornea. And histopathological examination, we can see the baby sawtooth pattern, which is suggestive of the Thiel-Wenger corneal dystrophy. So it is what is unique in our case, it is a rare condition which present at the younger age, and genetical and clinical diagnosis is essential. Clinical implication, the accurate diagnosis and role of imaging is important, and the surgical management is preferred in advanced cases. So take-home message is early recognition and genetical counseling are essential for managing hereditary corneal dystrophies. Advanced imaging techniques aids in the diagnostic, and SALC is an effective surgical option for visually significant Thiel-Wenger corneal dystrophy, and histopathological remains still gold standard. Thank you.
Thank you, Himanshu, for sticking to the time. You said genetic counseling is important. Can you tell us something a little about that? Because this is the part often you people miss. Whenever you see a patient of dystrophy, always call all the sibling and do have a look what's there, right? So, Himanshu?
So most of the corneal dystrophies are autosomal dominant dystrophies. They are progress in generation to generation. So proper counseling and is essential for the management.
Any comment from experts?
Yes. Honeycomb appearance in the middle, central or periphery?
In the middle, sir.
Middle, not central, but...
Central and paracentral, but not at the limbus.
Okay. Yes.
Thank you. So we move on to the next speaker, Dr. Amir Tha. Amir Tha, right? Okay. Next will be Ishita. So you please be ready for this podium, right?
Good morning. Today I'll be presenting a case on fungal keratitis. So fungus is one of the most difficult microbe to diagnose and treat. Fungal keratitis is an infection of the cornea caused by multiple fungi that is capable of invading the defect in the ocular surface. Globally, there's a prevalence of 6 to 20%. Coming to the case, here is a 9-year-old male child, informant father, who presented with a white opacity in the right eye with redness, pain, watering, and blurring of vision for 1 week. He had no history of ocular trauma, but his past ocular history included history of redness in both eyes with lymphadenopathy and fever, for which he was prescribed topical steroids for 10 days. His systemic history had no evidence of asthma, type 1 diabetes, or immunosuppressive treatment. His general examination was fair, and on ophthalmic examination, his right eye revealed a reduced best corrected visual acuity of 6 by 24 and 6. Retinoscopy showed a central opacity, and EOMs were full but painful. Rest were within normal limits. Left eye was also normal. So coming to the slit lamp examination, right eye showed a 3 into 4 cross mm epithelial defect of a corneal ulcer with surrounding infiltrate, feathery margins. The surrounding area also had a marginal edema with scarring. There was circumcorneal conjunction but AC was quiet and lens was clear, indicating it did not surpass the cornea. Left eye was normal. You can see the fluorescent stain under the cobalt blue light where you can see the size of the defect. The IOP and fundus was normal. We sent him for right eye scraping and started prophylactically on natamycin, voriconazole, and hometropin. In 5 days, the stromal infiltrate reduced, but the marginal edema remained. And in 15 days, he had a healed ulcer with a macular grade opacity, partially involving the visual axis. His vision subsequently reduced from 6 by 24 to 6 by 12, and his scraping revealed a septate filamentous fungi. And patient resolved symptomatically. Coming to the discussion, it's important to know the differential diagnosis of a fungal ulcer. In our case, we had feathery edges, but in bacterial ulcer, it can have a well-defined border. And in acanthamoeba, there can be a ring-shaped infiltrate. And in herpetic diseases, there can be dendritic or geographic ulcer. So, unique points of this case, though this is a straightforward fungal keratitis case, in pediatric age group, it is quite unusual. And in this child, there was a rapid progression within 1 week, highlighting the aggressive growth of the fungus. And it was merely just a short-term topical steroid use for 10 days. So we should be cautious with the steroids. Aggressive management is required with early intervention, though you don't get the results of the culture. Differential diagnosis is the key. As discussed, we shouldn't misdiagnose it as a viral or a bacterial keratitis. And risk of long-term visual impairment in children can lead to amblyopia. So take-home message, not all infections come with a cut. Even short-term topical steroids can be a silent trigger. Use steroids wisely in pediatric cases and educate parents and caregivers on self-medicating with steroid and not to delay with a specialist consultation. Thank you.
Thank you, Amrita. And it's a very important point. Steroids nowadays we are realizing, be it allergic conjunctivitis, be it any post-op inflammation cases, if you keep on giving steroid in pediatric cases, the glaucoma and all these things they go unnoticed, and also it alters the local flora that produces for subsequent fungal infections. Any comments?
Yeah, no, one thing is in treatment, what you wanted is thorough debridement. In fact, that is one thing along with the topical steroids. And because the penetration is less, they are lipophilic, so better to give intrastromal.
Yes, that you can try, but because we have done 3 studies on intrastromal, so just for you people, it's definitely good, but good alternative, but somehow it doesn't work all the time. I don't know why, but anyway, you should have tried that also. Thank you. Ishita, right? Yes, please.
Good morning, everyone. Today I'll present my case from cloudiness to clarity, a case of untreated endothelitis and its resolution. So the crumbling shield, how stromal keratitis breaks the epithelium. So persistent inflammation or stromal degradation causes the weakened stromal support, leading to disruption of the epithelial adhesion. Consequently, there is a direct endothelial damage due to the inflammatory cells that lead to endothelial pump failure, causing corneal edema that finally leads to the epithelial defect. So this is the case history. 62-year-old male presented with pain, redness in the right eye since 10 days. His BCVA was 6/18 parts in the right eye, while the left eye was normal, 6/6. In clinical findings, there was localized ciliary congestion from 6 to 7:30 o'clock hours with epithelial defect 3 to 4 mm size, 2 mm inside the limbus that was extending from 6 to 7:30 hours. There was localized fine irregular white KPs on the endothelium and the anterior chamber was quiet. And the posterior segment examination, there was no abnormality detected, while in the left eye, the anterior and the posterior segment was normal. So the probable diagnosis was made immune-mediated stromal keratitis with the loss of epithelial integrity. But which autoimmune disorder was responsible for this? So the culprit resided in the past history. Patient was a known case of psoriasis vulgaris and was on methotrexate 15 mg per week dosage since last 15 years. So the management that we did was he was given steroids as well as the antibiotic and the hometropine along with the lubricant and was followed up on the day and the dermatologist review was advised. Then on follow-up in the day 1 review, symptoms improved with vision improvement to 6/18, and on day 7 review, the symptoms as well as signs improved with best corrected visual acuity improved to 6/9. But on 3-month visit, there was a recurrence and that strengthened our diagnosis, where patient again complained of pain, redness, blurring of vision in the right eye since 10 days, and clinical findings were epithelial defect at the same location with stromal haze and thinning, and no dermatology review was done, and he had already stopped methotrexate since last 20 days. There was no AC reaction, hypopyon, or the corneal sensations were intact, and the endothelial KPs, they were persisting. So this is a case of recurrent keratitis at the same location with KPs persisting, diagnosed as chronic endothelial inflammation, immune mediated due to the psoriasis. So our differential diagnosis that was, it was not infectious keratitis because there was no ulceration or there were no infiltrates, no necrosis, stromal necrosis or ghost vessels, and while the AC reaction was no AC reaction was present. It was not marginal keratitis, neither a case of neurotropic keratitis or interstitial keratitis. While our favored non-infectious immune mediated because it was strong association with the autoimmune disease like psoriasis, and it responded to the steroids, and since there was persistence of KPs, we diagnosed it as endothelial dysfunction that happened over time. On literature review, psoriasis and keratitis, it has been found that ours was a rare case report of stromal keratitis associated with psoriasis. The literature that proved was psoriasis associated keratitis, analysis of densitometry and comparison of corneal biomechanical properties and ocular changes in patients with psoriasis. So the key takeaways from the case are autoimmune keratitis in patient, dig deeper into the history, consider psoriasis as a corneal disease, it's not just a uveitic one, and endotheliitis can be slow, silent threat, so consider doing specular microscopy and consider early diagnosis as long-term sequelae can lead to irregular astigmatism or low vision requiring rehabilitation.
Thank you, thank you. I think you have already crossed the time. So thank you so much. Samarpita is our next presenter. Yeah, please. Any comment meanwhile from judges?
Thank you.
After Samarpita, it's Naksham Mattu, right? So you'll be presenting from here. Right.
Good morning to one and all present here. Today I am going to present an interesting case of geographical keratitis. To introduce, herpes simplex keratitis is a common potentially blinding condition in which the virus remains latent in the dorsal root ganglion and can reactivate in conditions like immunosuppression. The initiation of oral and topical antivirals are the mainstay of treatment. A 66-year-old male presented to our OPD with the chief complaints of sudden, painful, profound diminution of vision in the right eye, along with redness and photophobia since 8 days. There was no history of any ocular trauma, and systemically the patient also had complaints of high-grade fever since 2 months, after which the patient was diagnosed with tubercular meningitis and was admitted under neurology in our hospital and was receiving injection dexamethasone, mannitol, and injectable along with oral anti-tubercular treatment since 6 days. On ocular examination, the visual acuity in the right eye was counting fingers 3 meters, which was not improving, and the near vision and refraction could not be assessed, and digitally the intraocular pressure was within normal limit. The eyebrows, eyelids, lacrimal apparatus were within normal limit. Lacrimal syringing was patent in both eyes, and conjunctiva in the right eye showed circumciliary congestion with palpebral conjunctival congestion. On corneal examination, the sensations were found to be reduced in all the segments, and a geographical shaped 7 into 4 mm sized paracentral epithelial defect was noted with scalloped margins, which was staining positive with fluorescein. The anterior chamber, iris, and pupil were within normal limit, and the lens showed nuclear sclerosis and cortical cataract in both eyes. The differential diagnosis of these were ruled out on the basis of the signs mentioned here, and provisional diagnosis of right eye paracentral geographical epithelial corneal ulcer secondary to a herpes simplex keratitis reactivation was made in a known case of tubercular meningitis, which was based on the history of systemic immunosuppression, reduction in corneal sensation, and geographical shape of the corneal ulcer with terminal bulbs. The management decided for this patient was to continue systemic antitubercular drugs and injection dexamethasone and to add tablet Acivir 800 mg 5 times per day along with topical eye ointment Acivir 5 times per day with cycloplegic and lubricants. And on follow-up after 1 week of presentation, the corneal sensation significantly improved. There was complete resolution of epithelial defect with some residual superficial punctate keratitis. What is unique in my case is that the patient was started on oral antiviral despite only having epithelial keratitis because the patient was systemically immunosuppressed. In this case, tuberculosis coexisted with herpes simplex keratitis, and there was complete resolution of the large epithelial defect within a span of 1 week, despite the patient being on systemic steroids. So the clinical implication is that a diligent history and examination is important with prompt staining and ocular sensation evaluation. Tuberculosis per se can also directly affect the eye with conditions like pectinulosis, uveitis, etc. And in such cases, early initiation of topical as well as systemic antivirals is important. Literature review of similar cases are these, and the take-home message in my case is that a geographical keratitis case must be properly evaluated, and initiation of oral antiviral should be started even in epithelial keratitis if the patient is immunosuppressed. Long-term continuation of oral antivirals are important, and proper clinical photographs must be taken for the analysis. And as the disease is highly recurrent, regular follow-ups is important for complete treatment of the patient. Thank you.
Thank you. Is there a mistake? I think you have written long-term oral steroid is required.
No, sir, that was antivirals. That is.
I think that's a typo. Yes. Please correct that. So steroids should be avoided in epithelial keratitis. That would lead to geographic. This is a very important point. If patient is immunosuppressed, which is there in most cases of herpes, and we often don't rule it out. In those cases, you have to give oral acyclovir for even for epithelial keratitis. Any comments, sir?
No, fine. No, so to prevent recurrence, oral acyclovir, but how long would you like to?
So for epithelial, chalo, you first answer, then I'll answer.
Sir, for as long as required could be 6 months to 1 year also.
So it has to be at least for 6 months, but best is please you have to give it for 1 year. And what is the amount of reduction in recurrence that you will get out of that? 40 to 50%. So don't tell the patient that since you are taking oral acyclovir, it won't recur. The patient will be after your life. You have to convey them, even if you are taking this, there is still a 50% chance that you may still get a recurrence. Okay, thank you.
Thank you, sir.
Naksham. After Naksham, Pranoti Patil. Pranoti, are you there? So please, you be ready here the moment she finishes her talk.
A very good morning to the respected judges and their fellow colleagues. I'm Dr. Nakshamatu from GMC Srinagar, and the topic of my presentation today is management of acute corneal hydrops with compression sutures and using desmetopexy. Acute corneal hydrops is a rare but sight-threatening complication of corneal ectasias. It occurs when the aqueous humor enters the corneal stroma through a spontaneous break in the DM and causes localized stromal and epithelial edema. It typically presents as an acute decrease in visual acuity along with pain and photophobia. Rupture of DM has been reported in association with keratoglobus, keratoconus, congenital glaucoma, intraocular surgeries, Terrien's marginal degeneration, acanthamoeba keratitis, and rarely spontaneously. Corneal edema typically clears within 3 months, but it can lead to posterior stromal scarring. Occasionally, stromal clefts can be seen in association with hydrops. These clefts usually close, but may result in corneal vascularization. Descemet's membrane rupture and detachments have traditionally been managed conservatively with a cycloplegic agent and topical steroid. Recently, studies have described newer surgical interventions like full thickness or pre-desmetic sutures, desmetopexy, thermokeratoplasty, and plasma injection that aim to close the posterior stromal break. With this case presentation, we aim to discern the results of using compression sutures with desmetopexy in a patient with acute corneal hydrops due to keratoconus. This is a short video in-drop video that I have put in of the case. First of all, we localize the break and we pass the suture through it. 10-0 nylon is normally used. Then we buried the sutures. We use air. In this case, we used air for desmetopexy. The burying of the corneal sutures was done. And a BCL was put on at the end. This is the pre-operative picture. On the right side, we have the pre-operative picture of the patient, and on the left side, we have the first post-operative day following compression sutures with desmetopexy in the patient. This is the anterior segment OCT of the when it was a pre-operative case. And this is the post-operative picture of the same patient. We can see the BCL, the tear film, and the suture marks are also seen here. There's marked reduction in the thickness as well as in the presence of stromal edema. This was an 11-year-old boy. His name was Yasser. He had...
you have to summarize. Your time is up.
Okay, sir. He had, it was present in the right eye, and there was a marked reduction in the post-operative, when we saw the patient post-operatively. What was unusual about my case, that we saw markedly reduction in the corneal thickness even on the first post-operative day, which is unusual. That's it, sir. Thank you.
Thank you. Any comment from the judges? You said it was a bilateral hydrops, right?
Sir, it was not at the same time. So there was
okay.
We had done the left eye.
So once there is a hydrops in one eye, any process you should do in the other eye?
The hydrops, so we can put the patient on.
So always consider for CXL, right? Yes, CXL can reduce, although data is not there, but it can still help you in reducing the occurrence of corneal hydrops in the other eye.
No, sir, actually, ASOCT prior to surgery will tell you where the cleft is and what should be the orientation of your suturing. Okay, and then the sutures that you put, they should be through and through, continue, so that you are going to close the cleft. Then you can put the air or C3F8 or whatever.
Okay, sir.
So
Okay, sir.
Have you heard of a technique, intrastromal fluid drainage for hydros?
So I read it in one of your papers, but
Go back and study. That is from our center. That is my paper basically. Okay, that is also a technique you can do in recalcitrant hydros. Okay,
Okay,
thank
sir.
you. So Pranati, yeah, please.
Good morning, one and all. My title is Healing Against the Odds, Hydrops After Dalk. As we all know, keratoconus is a progressive primary corneal ectasia. Acute corneal hydrops occurs in advanced keratoconus due to break in the descent membrane and aqueous intrusion resulting in a stromal edema. DALK is the preferred surgery for advanced keratoconus, preserving the patient's endothelium. Corneal hydrops post DALK is extremely rare, with most cases requiring further surgical intervention. So here I am presenting a case of 10-year-old boy with bilateral keratoconus with progression in left eye after corneal collagen cross-linking. So patient underwent manual DALK in left eye. Surgery was uneventful and post-operative visual acuity was 612 following suture removal. Patient presented a year later with a decrease in vision in left eye of 1 week duration post history of vigorous eye rubbing. Visual acuity was hand movement plus PL plus PR accurate. On examination, we noted conjunctival congestion, corneal graft showed microcystic and stromal edema with detached descent membrane involving the central and inferior cornea with a relatively clear cornea in superiotemporal periphery. Intraocular pressure was 24 millimeters of mercury. We started him on lotipride eye drops 4 times a day, timolol 0.5% eye drops 2 times a day, and 1% atropine eye drops once a day. On 8th day, vision was improved to 5/60 and intraocular pressure was 18 millimeters of mercury. On examination, there was reduction in stromal edema and spontaneous reattachment of the descent membrane with the fibrosis more evident in inferior quadrant. After 2 months, best corrected visual acuity was 618 with stromal scarring and inferiorly fibrous descent membrane. What is unique in my case? Only one case of acute corneal hydrops 52 months post big bubble dark surgery has been reported so far. Corneal hydrops post keratoplasty differs from that in the advanced keratoconus in that it is typically starts at the graft host junction, most commonly in inferior cornea. Conventionally, these cases require surgical management for descent membrane reattachment. However, in our case, there was good anatomical and visual outcomes with conservative management. Clinical implication: acute hydrops post DALK is a rare phenomenon, with eye rubbing being the most common inciting factor. The retained keratocytes from manual dissection could also be factor involved in disease recurrence. Our case highlights the importance of preventing eye rubbing and IOP spikes in a patients with successful DALK surgeries to prevent disease progression and complication. Thank you.
Thank you. And are there any evidence to prevent IOP spikes to prevent hydrops?
Sorry, sir.
Your last message was like avoid eye rubbing and IOP spikes.
Yes, sir.
So is it based on any previous studies or?
His
See, eye rubbing is definitely associated with
Yes.
hydrops, but what about IOP spikes?
His intraocular pressure was 24 millimeters of mercury. So we assume because of raised intraocular pressure, that can also be the one cause for hydro.
Maybe,
Unlikely.
but
Maybe following LASIK, no, what we used to see that
yes,
subflap, this thing, the fluid.
could be that.
After LASIK, yes.
But there is no evidence that suggests spikes in IOP can lead to hydrops. You know, if somebody asks you, your answer should be yes. Trauma in form of eye rubbing or any trauma can precipitate hydrops. But IOP spikes may be there may be two associated but not causal factor, right?
Yes.
So that is remember. Thank you.
Thank you.
Pratik, are you there? Yes. After Pratik, it will be Renuka. So please be ready. So you have this program book, right? I put it in the group, PG Capsule group, and this is the sequence. So please be ready. The moment your preceding speaker is done, you please be ready on the other podium, right?
Good morning everyone, I'm Dr. Pratik. The title of my case is Glue to the Rescue. So deep anterior lamellar keratoplasty is a corneal surgery done in case of advanced keratoconus, and descent membrane microperforation and detachment is a known complication associated with this surgery, and it is usually managed with air tamponade. This is a case of DM detachment managed with fibrin glue. A 24, thank you, sir. A 24-year-old male with bilateral advanced keratoconus status post CXL has developed corneal stromal haze and was advised for deep anterior lamellar keratoplasty in the left eye. So during the DALT surgery, manual dissection was done after a failed attempt to obtain big bubble, and during which there was DM microperforation and leading to DM detachment, and air tamponade was done intraoperatively. On the post-op day 1, we can see central DMD extending superiorly and nasally even after air tamponade. And there is a post-op day 1 ASOCT showing the DM detachment. So the following the day, the patient was taken up for resurgery to DM attachment using the fibrin glue components. So the suture was removed and the interfaced fluid was released. And then a temporal paracentesis was done and air bubble was injected to further release the interface fluid. And later full chamber air bubble was injected and the fibrin glue components were applied sequentially. And it was left for 2 minutes, and then this graft host junction was sutured. And after placing bandage contact lens, the case was closed. And we can see the following day the ASOCT showing hyperreflectivity in between the host DM and the donor stroma, showing fibrin glue in the interface. And the fibrin glue components resolved 20 days post-op. And this is a post-op 2 months post-op photo showing complete resolvement of the fibrin glue components and attached DM superiorly and nasally. So unlike the vastly used air or pneumodesmatopexy or suture desmatopexy, fibrin glue was used here, and it's a biological tissue adhesive which was minimally inflammatory in nature, and this helps in decreasing the need for air tamponade and post-op positioning. It also helps in decreasing the risk for pupillary block with high IOP, post-op fixed dilated pupil, cataract, and posterior synec formation. So take-home message is fibrin glue can be a valuable adjunct or option in management for microperforation of DALC intraoperatively or postoperatively. Thank you.
Thank you, Pratik. Renuka? Yes, Pratik, you are the surgeon?
No, sir, our consultants.
Okay, so who is your mentor?
Sir, Dr. J.K. Reddy, sir.
J.K. Reddy, sir, LB person?
No, sir, from Shankara Hospital.
It's Shankara Hospital, okay, J.K. Reddy, sir. So, okay, nice videos. And normally we do suture only, but this first time I am seeing somebody putting glue also. So, do you think this is only glue or suture plus glue?
It was
that
only
is
glue,
working?
sir. Only glue, I think.
No,
Thank
but I mean, video showed suturing
Suture
at the
also.
end, no?
No, so
suture
the
plus
suture
glue.
was removed from the graft host junction in the starting, so it was resutured again.
Okay. But I think both are working, not the only glue part.
But I mean, for me, I have not used fibrin
Yes.
glue in the interface. Yes, yes.
But it's a nice concept. Thank you.
Thank you, sir.
Renuka, please go ahead. After that, Subham.
Good morning, everyone. Today I'll be presenting a case on the title Mitomycin C, the resolution and the problem. No financial interests or conflicts to disclose. Introduction. Ocular surface squamous neoplasia encompasses a spectrum of epithelial tumors. Surgical excision followed by histopathological excision remains the gold standard for ages. Recently, medical therapy has an advantage of treating the entire ocular surface and decreasing the recurrence rate. The options we have include mitomycin C, 5-fluorouracil and interferon alpha 2b. Mitomycin C can be used either as a standalone as well as an adjuvant therapy. Adverse effects include conjunctival hyperemia, epitheliopathy, and punctal stenosis. This is a case of a 60-year-old female presented with complaints of lesion in a wide part of the right eye for the past 10 months, which was incidus in onset, not progressive, not associated with pain, with history of intermittent grittiness present. She had a previous history of similar lesion in the right eye, for which excisional biopsy was done, and the HP reports were suggestive of ocular surface squamous neoplasia. Post 1 month after her excision, she recurred with the similar symptoms, and the presenting visual acuity was 6/9, and the conjunctiva showed a pinkish fleshy papilliform lesion of size 5 cross 2.5 mm along 2 to 4 o'clock position with a prominent feeder vessel could be seen here. And the ASOCT showed a hyperreflective epithelium with
posterior shadowing and abrupt transition of the epithelium could be seen, and a diagnosis of right eye recurrent papillomatous ocular surface squamous neoplasia was made, and she was started on eye drop mitomycin C 0.04% QID for 4 days, followed by a drug holiday for 3 days, and this was repeated with a 12 cycle and substituted with a preservative-free carboxymethylcellulose. This is the 6-week follow-up image where you can see the lesion being resolved, and this is 3rd month follow-up image where the lesion resolved and with vascularity is also regressed and pigmentation could be noted. 2 months post MMC therapy, the patient presented with a decrease in visual acuity. Under examination, we could see the haziness with heaped epithelial margins, and the haziness was distributed up to the stromal level in a centrifugal pattern. On staining, irregular stain uptake was seen, and superficial vascularization was noted. Epithelial defect was diagnosed, and she was started on copious lubricants. But 2 months post lubricant therapy also, epithelial defect persisted. So limbal stem cell deficiency was suspected here, and she went for epithelial debridement with amniotic membrane grafting and bandage contact lens. This is the 1 month post-op picture of the same patient after removing the BCL, where the haziness has reduced and there was no epithelial defect, but pooling was present, and integrated AMG could be seen in the margins, and haziness and vascularization has regressed. MMC inhibits active keratocytes and exhibits non-specific cell toxicity. Incidence of limbal stem cell deficiency in patients receiving longer cycles has been reported. It can present as abnormal irregular epithelium with irregular stain pattern. Management in case of LSED include eliminating the offending agent, preservative-free tear substitutes, and band-aid contact lens. In case of refractory cases, AMT helps by forming a scaffold for re-epithelialization, anti-inflammation, and decreasing vascularization and scarring. Take-home points: MMC, an anti-metabolite, has its action specific to the replicating cells. This has also led to its toxic effects such as LSCD and persistent epithelial defect. Punctal occlusion and pulsar dosing can aid in reducing the toxicity, and further studies regarding appropriate concentration of MMC in suspected individuals are mandatory. Interferon alpha-2b is a safer alternative with lesser side effects. Thank you.
Thank you, Shubham. Please be ready with your PPT. So, Renuka, what was the duration for which you applied MMC?
Sir, we gave 12 cycles.
1 cycle. With that only there was LSCD.
Yes, sir.
Okay. So, and you follow
Because
this 1 cycle on off that pattern, right?
Yes, sir. Maybe she had a history of excision also. That is also a contributory factor for limbal stem cell deficiency.
Okay. Thank you, Shubham. You are ready? Okay. So after Shubham, it's Tulika. Tulika, are you here? She will be presenting from there. Huh? Please be ready.
Right. Good morning, everyone. Okay, sorry. Good morning, everyone. So I'm going to be presenting a quirky case of a perfect vision with an imperfect outcome. But before that, let me not get ahead of myself. To start with, a 24-year-old female with no pre-existing comorbidities came to us for a refractive surgery opinion. Her refraction in the right eye was 5.5 diopter sphere and -1 cylinder. In the left eye was -4.5 diopter sphere and -0.75 diopter cylinder. Her slit lamp examination was perfectly normal. Her anterior and posterior segment, including the tear film, was absolutely normal. We investigated her and we found that she had a normal corneal tomography, normal corneal thickness, and normal corneal biomechanics as measured on pentagram and corvus ST. So given the normal findings, the patient then underwent an uneventful CLEX procedure. Well, given the uneventful surgery, we did not expect any surprises, and rightly so. Her visual acuity on postoperative day 1 was 20/20 in both eyes. Her anterior segment examination showed a fairly healthy superior side incision with a clear interface, and everything else was pretty much within normal limits. Given the findings, we were expecting to see a smiling patient, but we were instead greeted with an unsightly frown. Our patient still complained of blurring of vision and glare despite reading 20/20 on Snellen's chart. So we went ahead and did an aberrometry evaluation with eye trace. And behold, she did have suboptimal visual quality due to scatter of light. At this point, we were wondering what was causing the scattering of light. We could have just sent the patient off with lubricants, but we decided to go ahead and investigated her further. We then ordered a pentacam OCT. Now, this pentacam OCT revealed, with its high resolution, it was able to pick up micro distortions or wrinkles in the Bowman's layer. Now, thus, in the absence of any clinical findings that can explain the patient's symptoms, we can infer that the Bowman's membrane micro distortions are the cause of the patient's suboptimal vision. And such findings have indeed been previously reported as well. So the take-home message for my case is never dismiss a patient's complaints. Use all the tools available in your arsenal, even if the symptoms are not explained by the current clinical findings. Tight dissection or excessive manipulation during clicks can cause Bowman's microdistortions that can lead to suboptimal visual quality. And cap ironing is a crucial step that should be done post-lenticular extraction to reduce these microdistortions. These are my acknowledgements. Thank you.
Thank you, Subham. So that's a nice concept. Cape ironing. Any comments, sir?
No, how was this case managed?
Because we could not do the cap ironing post-operatively, we just reassured the patient, and within the 1 month follow-up itself, the patient was a little bit better neuroadapted to the distortions in the vision.
No, I mean that undulations in the Bowman's membrane, no? They
So
became all right?
they did not resolve, but there was neuroadaptation eventually, and then she was able to live with it.
Patient realized.
Thank you, sir.
Yeah, Tulika, go ahead. After Tulika, it's Koel. Koel, are you there? Yeah, please, you be ready here.
Good morning, everyone. The title of my presentation is The Other Side of Cure, Ciprofloxacin and Corneal Deposits. So introduction for the ciprofloxacin corneal deposits is ciprofloxacin is a widely used fluoroquinolone, which is a second generation fluoroquinolone, which is a broad spectrum antibiotic, and it is widely available in India. The ciprofloxacin corneal deposits have been associated with it, and many reports have been documented. It is relatively uncommon, but they have been particularly documented in patients treated for bacterial keratitis following ocular surgery such as corneal grafting or even LASIK. These deposits typically present as white or yellowish precipitates on the corneal surface. Since the ciprofloxacin is soluble at a pH of 4.5 and the tear film pH is approximately 7.2, it becomes less soluble, leading to the potential precipitation onto the corneal surface. The case that I am presenting is of a 76-year-old one-eyed patient with ulcerative keratitis in the left eye. The patient was PL negative in the right eye and had finger counting of half-meter vision in the left eye. When microbiological corneal sampling with culture and sensitivity was sent, it showed coagulase negative Staph aureus positivity, and the patient was started on ciprofloxacin 0.3% eye drops. When the patient presented 2 weeks on follow-up, corneal deposits were seen in the epithelial defect as seen in the picture, along with corneal infiltrates, stomal necrosis, and corneal neovascularization. Since we had already sent the culture and sensitivity, we could easily switch the patient to another eye drop, which we knew that the patient was sensitive for. So when ciprofloxacin was discontinued and switched to polymyxin B and chloramphenicol, along with atropine and lubricants, patient was kept on close follow-up, and eventually the ulcer healed with leukomatous scarring. Low-dose topical steroids were also later added to decrease the post-ulcerative scarring. Final vision was finger counting at 2.5 meters. No significant visual improvement was there due to the central nature of the corneal opacity. What makes this case unique is that the patient was one eye, therefore the patient had only one functional eye, which made this a high-risk case. The patient showed coagulase negative Staph aureus infection positivity, which is a typically less virulent organism, suggesting that it could be due to host factors such as increased age or compromised ocular surface. The treatment challenge therefore required careful antimicrobial selection and balancing infection control while preventing further toxicity or complications. Ciprofloxacin corneal deposits can be concerning, but they resolve spontaneously on discontinuation. Adjunctive treatments such as lubrication and preservative-free artificial tears may aid in the process. It is important to note that the ciprofloxacin deposit must not be confused with corneal infiltrates, and the likelihood of developing corneal deposits increases in presence of epithelial defects, severe ocular surface disorders, or multiple medications which alter the pH of the ocular surface. So the ulcerative keratitis requires aggressive treatment and management to preserve vision, early recognition of the complication to change the medication so that the patient must be kept on close follow-up, and early
Tulika, I think we have to wind up now. Yes, any comments from the judges? Meanwhile, Coil, will you please be ready with your PPT?
The drug is with
Deepti, Dr. Deepti.
Preservative free or with preservative?
So after the corneal deposit, the patient was put on preservative free eye drops.
Preservative after that.
Yes, because the phosphate experience
Okay.
Harnoor Jot, yeah,
Thank
please
you,
come.
No, but correct. This can be a question in the exams. Actually, there are so many causes for deposits in the cornea, and fluoroquinolones are, as such, they are known to cause, but ciprofloxacin is the worst. Usually, they recover within a month or two. Okay, with just lubricants, as you said, but there are other causes also of deposits. Okay. Yes.
Thank you, sir.
So, good morning everyone. Today I am presenting a case of a limbal dermoid. There is no financial disclosure. So, first of all, this is a golden heart syndrome which is characterized by the classic oculo-auriculovertebral sequence of mandibular hypoplasia, and it results from the errors in the morphogenesis of the first and second branchial arch. So the incidence is 1:3,500 and 5,600 with male and female ratio 3:2, and abnormalities are unilateral in 75 to 85% of this case. My chief complaints is the 4-year-old boy presented to RIO Kolkata with his parents, and parents noticed a small lesion near the black area of the left eye of the child since birth. Antenatal history is taken. Mother had a gestational diabetes mellitus and gestational hypothyroidism was present. So this is the risk factor for this case. So ocular examination is done. The visual acuity at presentation in the left eye 6/24, pupil round regular reacting to light. Other things are normal, but in cornea there is a limbal dermoid 350 micron encroaching into the mid stroma, and the EOM free and full in all gauge and direction. Fundal globe present in both the eyes. So these are my photographs: the polydactyly and cleft lip, and this is the pre-auricular skin tag and the limbal dermoid present in the left eye. AS OCT was done. There is a 350 micron encroaching into the mid stroma. There is a limbal dermoid. So my professional diagnosis is, this is a case of a golden hair Gorlin syndrome, which is characterized by classic oculo-auriculovertebral sequence of mandibular hypoplasia, and this including the limbal dermoid, pre-auricular skin tags and pits, and the cleft lip. So my unique features is only the eye involvement, ear involvement, and mouth involvement. There is no anomaly in vertebral hypoplasia. So management, the child was managed by excision of the limbal dermoid in the left eye with implantation of the amniotic membrane with fibrin glue. This is my post-op day 1. So this is a published literature which is fibrin glue assisted multi-layered amniotic membrane transplantation in surgical management of pediatric corneal limbal dermoid. This is a novel approach, and clinical implications are multi-organ involvement first of all. Second, there is a difficulty in airway and anesthesia management, and speech and developmental delay may be there, or psychosocial impact. The take home message: a well equipped arsenal is needed to win any battle. So we are the ophthalmologist referred the patient to any plastic surgery for microtia management, and also the ENT surgeon and laryngologist, and this is my sincere gratitude. Thank you.
Thank you so much. Nice use of Gandhiji's advice in your PPT. Any comment from judges?
Common site of limbal dermoid?
Harnoor, you are next.
Inferotemporal, sir.
Inferotemporal.
No, one thing here is already amblyopia is there, 6/24 was the vision, and then when you cut the stroma and put only amniotic membrane, definitely astigmatism is going to be high, isn't it?
Yes, sir, but
yeah, correct. And superficial dissection of the thing. If you want to go up to the mid stroma, then the best thing would be to do a lamellar keratoplasty in that
yes,
area,
yes,
so that astigmatism can be
in
taken
this case
care of.
we have not done.
So in fact, sir highlighted a very important point. Whenever you see a patient of limbal dermoid, you know the most common cause of vision loss is amblyopia due to uncorrected refractive error. So always prescribe glasses. If you are not able to handle that case, if you are planning to refer, do a good refraction, prescribe glasses, then refer the kid. Okay. Thank you.
Okay, sir. Thank you.
Yes, Arnur.
Good morning, everyone. Today my topic for case presentation is therapeutic keratoplasty in young male with fungal keratitis. First of all, what is fungal keratitis? It is a life-threatening corneal infection that can progress rapidly if not managed effectively. In our case, it is highlighting on 19-year-old male with non-healing corneal ulcer despite intensive medical therapy. Given the risk of progression and limbal involvement, therapeutic keratoplasty has performed to control the infection and restore the corneal integrity. Our case is a 19-year-old male, student of Kanpur, came with the chief complaint of diminution of vision, pain and redness. The diminution of vision was gradual in onset and progressive. The pain was sudden and pricking in nature and gradually progressive. And redness was sudden and increased in a few days and remained static, and with also associated with watering and whitish appearance in the black area of the eye, which is gradually increased in size since 3 weeks. Patient ignores his symptoms in the first few weeks, and after with the local practitioner, he was taking natamycin, then moxifloxacin, atropine, and timolol and voriconazole 1%. And patient also gave a history of vegetative stick matter trauma history of 3 weeks back in the right eye. On examination, his visual acuity was finger count, and on slit lamp examination, we had a 7 into 6 mm whitish grayish stromal infiltrate with feathery appearance and rough without any slog, and the epithelial defect was 5.5 into 5.5 mm with no endo exudates, no satellite lesion. And the corneal stroma edema was present with surrounding the infiltrate, and the hypopyon was approximately 3.5 mm in height. On KOH, when we did the scraping, we sent the sample for KH, we had the septate hyphae seen, and the blood agar was also showing a fungal growth suspecting of aspergillus. We planned according to the age was the patient was young and there was limbal involvement. The patient was already taking medical regime for 3 weeks. We also have a good corneal tissue available. We planned for therapeutic penetrating keratoplasty was done with voriconazole wash, and the donor size was 9 to 5 mm, and the recipient graft was 8.5 mm. After the visual acuity was done on day 7, which was about to be 6 by 36, with we have the pupil mid dilated, and the iris pattern was normal, and the graft host junction was also normal. Within 1 month, the vision was 6 by 12. The unique about my case was the patient was 19 year, which is unusual for severe fungal keratitis requiring for therapeutic penetrating keratoplasty. And the unlikely many cases with fungal keratitis leads to multiple surgery, and the patient underwent early TPK within 3 months leads to good vision recovery. And clinical implication that if we have a large ulcer and limbal involvement, we have to go for TPK.
Thank you, Purva. So, any comment from the judges? Fine. Next will be Sakshi. So, one point, fungal keratitis, there is always a debate whether to go for early TPK or late. But this was a case of infection following
immunosuppression.
Trauma.
Yes.
Okay. Okay, but when she is right, if it is severe to begin with, and if it is not responding, then at times few surgeons they take a early call. Thank you. Yeah, Sakshi.
Good morning, everyone. Today I'm going to present the case of viral keratitis caused by acyclovir-resistant herpes simplex virus, which responded well to ganciclovir. Herpes simplex keratitis is a viral infection of the cornea, that is the clear part of the eye, caused by the herpes simplex virus. HSV keratitis often recurs, and severe or recurrent infections can lead to corneal scarring and vision impairment. How does it spread? Direct contact. It spreads through direct contact with someone who has an active infection such as a cold sore. Then due to reactivation also it can spread, as many people are infected with HSV, but the virus remains dormant and it can reactivate and cause outbreaks including eye infections when the immunity decreases.
My patient was a 38-year-old female resident of Kanpur, housewife by occupation, and came with the chief complaint of pain, which was progressive in nature, irritation, which was also progressive in nature, redness, which was sudden and progressive in nature, and diminution of vision, which was gradual in onset and progressive in nature, both for distance and near. She visited an ophthalmologist nearby and was prescribed tablet acyclovir 800 mg 5 times a day, and eye ointment acyclovir 3% 4 times a day, but it showed no improvement. No history of similar episodes in the past. She is vegetarian by diet with normal bowel and bladder pattern and normal sleep cycle. The visual acuity was 618 and which improved by pinhole with to 69 partial. Now, the epithelial lesion with terminal bulbs was seen. These are the positive findings seen over central cornea, which was visible on fluorescent staining, and there was surrounding epithelial haze, and the corneal sensations were reduced. The plan in our center, we started eye ointment 0.15% ganciclovir 5 times a day for 1 week, then eye drop tear fresh, which is a lubricant, 4 times a day for 1 week. Then resolution of symptoms was seen, mild healing of a dendritic ulcer with only a very minuscule superior central corneal involvement left, and visual acuity improved to 6.9. Then after 1 month follow up, there was further improvement. Now, what is unique in my case? Viral keratitis caused by acyclovir resistance herpes simplex virus is relatively uncommon. The virus was resistant to acyclovir but still responded well to ganciclovir, and this is a thing to be noted, as ganciclovir is typically reserved for more serious or resistance infection often in immunocompromised patients. This suggests that the virus resistance mechanism was specific to acyclovir and did not extend to ganciclovir, highlighting the effectiveness of ganciclovir in such resistant cases. Now, the mechanism of action of acyclovir was its selective activation of by viral thymidine kinase and conversion to acyclovir triphosphate, and subsequent inhibition of viral DNA replication by incorporating into the terminating the growing viral DNA chain. And the mechanism of ganciclovir was inhibiting viral DNA replication through the conversion of ganciclovir to its active triphosphate form and acting competitively as a competitive inhibitor of viral DNA polymerase. Clinical implication: acyclovir resistance should be considered in cases.
Yeah, wind up. So any patient who is not responding to acyclovir, that should be done. So any what was the method you used to diagnose resistance?
The patient was resistant to acyclovir, so we can give ganciclovir in such patients.
Then how to diagnose? Suppose somebody is not responding, whether it is due to acyclovir resistance or due to some other factor. How will you know that?
Symptoms are not improving.
So one is clinical C is right, what you do, but to confirm, if you want to publish, then you have to go for some cell-based studies. For keratitis, we do this micro-broad dilution technique, fungus, bacteria. But virus, it is difficult because they infect the cells. So you have to go for cellular models. Thank you. That was a wonderful talk. And in fact, resistance is a common problem seen nowadays in keratitis. I think Apurba, you are still, yes. But last presenter will be Dr. Apurba. Please, you come here. Yeah, after that, sir will be. Apurba Dige, yes. You don't do anything, they are doing that. इसमें दिखा दो कौन सा तुम्हारा कौन सा
Good morning, everyone. A phakic intraocular lens is an artificial lens planted in the anterior or posterior chamber of the eye in the presence of a natural crystalline lens. It is used to correct refractive errors, especially in thin corneas where laser correction is not possible. So I am presenting a case of a 24-year-old female presented with pain, redness, watering in the right eye since 1 year, blurring of vision in the right eye since 1 year. She underwent right eye ICL surgery 1 year back and gives history of no improvement of vision and redness, watering, and 2 episodes of vomiting on the first post-operative day. She gives history of using glasses since 15 years. Her visual acuity in right eye was 6 by 36, not improving with glasses, and in left eye it was 2 by 60, improving with correction to 6 by 6. The intraocular pressure in right eye measured with applanation tonometry was about 32 mm of Hg, and gonioscopy revealed peripheral anterior synechiae in 3 angles. Right eye anterior segment examination had mild ciliary congestion. Cornea revealed few epithelial bullae with stromal edema. There were peripheral anterior synechiae in superior, inferior, and nasal quadrants, and iris had atrophic patches present more inferiorly. PI was present at 11 o'clock, it was patent, and phakic IOL was present. Left eye was normal with the PI at 2 o'clock. Fundus examination was normal. Right eye ASOCT showed a vault of about 890 microns, which was a high vault. Anterior segment OCT also revealed pass in 3 quadrants with central corneal thickness of about 600 microns. Specular showed a decreased endothelial count of 926 in the right eye. UBM revealed pass and anterior bowing of the iris. So patient was diagnosed to have decompensated cornea with synechial angle closure glaucoma, status post IPCL surgery. She was started on anti-glaucoma medications. At 4 months follow-up, the intraocular pressure was maintained, but there was worsening of stromal edema. So surgical plan was done. She underwent Descemet stripping endothelial keratoplasty with synuclear lysis, IPCL explantation, and with phacoemulsification and foldable IOL implantation. 1 week post-op, her visual acuity was 1 by 60, with pressures were 16 mm of Hg by tonopen. The DSEC graft was in C2 with mild edema. 2 months later, visual acuity improved to 6 by 36. Intraocular pressure by tonopen was 13 mm of Hg. The DSEC graft was in C2, clear, graft interface was clear, and host cornea had mild edema. So in this case, patient underwent a complicated IPCL surgery. Most likely cause was toxic anterior segment syndrome, and high vault was also an additional factor which caused worsening of the condition. So usually the chances of TAS following ICL are very low as compared to cataract surgery plus IOL. Very handful of cases have been reported, as ICL surgery takes lesser surgical time, lesser steps, and lesser entry of toxic substances. Patients coming for refractive surgery have very high expectations, and occurrence of a TAS can be very can create a difficult situation. So some points to prevent PAS are cleaning, sterilization of all instruments, using intracameral ducts without preservatives, using fresh OVDs. The tips of lens and instruments should not be touched, and it is better to use powder-free gloves. So detailed preoperative evaluation should be done before selecting patients for phakic IOLs. Early suspicion and aggressive steroid treatment can prevent sequelae of TAS. Thank you.
Thank you. In fact, TAS is a major problem, and you are right. With ICL, the incidence is very low, but when it occurs, you have to treat it aggressively, because refractive patients, the vision was 6/6 and corrected, right? So anything less than that is not acceptable to the patient. So thank you. Now I would like to invite KB Satyamurthy sir for a keynote talk on DSEC. Why DSEC? Because when I was going through the different cases, there were 5 cases on endothelial problems. So I thought this talk should be there. I wanted to have on hydrops also, but due to time constraint, I couldn't put that. So welcome, sir. Sir is an excellent teacher, excellent corneal surgeon, and sir has come from a long distance for this session. Thank you so much, sir.
Yeah.
Please go ahead with the talk.
Thank you. At the outset, I'd like to thank Dr. Praful Maharana for giving me this opportunity. And since most of you are students, so I'd like to go stepwise. And then, though it is mentioned at DSEAEK, that is a Descemet stripping, automated endothelial keratoplasty, but I am doing manual DSEC. So I'll stick to my method of doing. Basically, as we discussed, the endothelium, which is responsible for maintaining the detrusgence of the cornea, it gets you develop bullous keratopathy. So only that layer is replaced. This is component replacement surgery. All you have to do is just endothelium with a Descemet's membrane, and about 100 to 150 microns of the stroma is taken in. And then you have other modalities of treatment also, like DMEC, then there's PDEC, so all these things. So, but this is what, so now the indications are all those conditions where the endothelium is defective. So probably following cataract surgery, which results in pseudophakic bullous keratopathy, which is of late, the incidence has come down so much because of good viscoelastic substances and good technology, that is emulsifiers. And then this is another important thing which may not be very common, but still that can throw surprises post-operatively, especially when the endothelium is not healthy in Fuchs endothelial dystrophy. So you have done uneventful surgery, and next day, to your surprise, you see a lot of edema. So probably if you just look pre-operative evaluation with the corneal, specular microscopy, it'll tell you all these things. And then it's important to know about this for various reasons, whether to do the cataract surgery and do the DSEC at the same sitting or not. Anything less than, if the patient is younger than 40 years, then you can do only DSEC if there is this thing. If the endothelial is decompensated, or if it is more than, if the patient is more than 40 years, then you can combine cataract surgery along with the DSEC, okay, or DMEC, whatever, endothelial keratoplasty. And then sometimes the endothelial rejection, which is very common in following post-penetrating keratoplasty, is that there is the worst type of disease that we can have. Graft rejection, it can be graft failure also because of defective endothelium. You can do this. And then the contraindications are in case if there is significant scarring in the center. So only endothelial keratoplasty is not going to help at all. And then if following previous penetrating keratoplasty, if there is irregular astigmatism, or if there is high astigmatism, again it's not going to help. So what is the pre-op evaluation? This is basically to decide, to plan the surgery. If the patient has got cataract, you'll have to plan along with the endothelial keratoplasty cataract surgery also, if there is a significant scarring or not. Sometimes it may look white, but if you do anti-segment OCT, you will come to know that it is only the epithelium which is edematous. Underneath the epithelium, the stroma is clear. So all you have to do is debride the epithelium, and you can go ahead with endothelial keratoplasty. If there are iridotomies, or if there is aphakia. Why aphakia? Because the air tamponade that we use, the air tends to go into the vitreous cavity, and then that can result in the graft dislocation. So better to correct aphakia, and if peripheral anti-seneca, you will have to correct that. If there is vitreous, again you will have to plan for antivitrectomy. So now coming to the instrumentation that we have, this is very important. This is the most important thing is this artificial antechamber. This is the base, and then you have a pedestal. At the top of the pedestal, you can mount the corneal button, corneoscleral button, which is around 13 to 14 millimeters. And then you have a locking tissue retainer, and then there is a locking ring here. So it's available both as a disposable as well as the reusable things in steel or the platinum with the metallic artificial antechamber. And then the instruments that we use for dissecting the cornea at the plane of say around 400 or 450 microns is this. So these are the blades which are used. Now every company has got its own design. Now they are also available as disposable things. Then you have the reverse Sinskey hook, which is to strip the descemetes, because the DSEC is descemate stripping endothelial keratoplasty. You can use 26 gauge needle also. We'll see the video later on. And then depending upon the type of insertion of this lenticule, that is a Donner's lenticule, then we have either the forceps where you can hold it at the tip has got curvature. Then you can use boosting glide. Then there are a lot of endo inserters. Based on this, there are a lot of techniques, whether you can fold the thing into the form of a taco and then place it so that the stroma goes up and then it opens up the endothelial side down, or you can push the whole thing, which I'll show. And then depending upon the type of thing that instrument that you use, either boosting glide or the endo inserter, you can have the surgical technique. So now I'll just show you the push technique, which is simple, and this is the artificial antechamber onto which tissue is mounted, and this what you are seeing here is the preset knife. So you are going to make an incision at the corneoscleral junction, which goes up to about 400 microns or 450, depending upon what knife you are going to use. It's always ideal to use, say, anything more than 400 microns, because the corneal tissue is, say, in the center. If you take as 500 microns, in the periphery, it will be somewhere around 800 to 1000 microns. So if you start at 400 microns level, then probably you will be having 100 microns in the center. So once you dissect this, yeah. So now you have made a cleavage. Now you are going to make a plane. This is exactly at the 400 microns. So better to lift the tissue and then you start there. And this is the dissector. So this is a disposable dissector. So your idea is to dissect at that plane from end to end, that is from limbus to limbus, 360 degrees all round, so that when you punch the corneal button, so it is, there are no attachments anywhere, and then you make a mark on the end of on the epithelium, so that acts as a guideline. So that can be stained with the trypan blue, and then this is the reverse Sinskey hook, with which we are going to strip this. So that is called the endothelial scoring, the Descemet's scoring, and then you can strip the Descemet's. It's very easy when you do cataract surgery to, because that is how the Descemet's behaves. It gets stripped, but while stripping sometimes it may not come so easily. So all you have to do is just strip the Descemet's. See, here I showed you the way injecting visco, but it's ideal to avoid visco. So paracentesis is made exactly 180 degrees apart, and then once you strip the Descemet's, you enlarge the incision. This is the scleral tunnel, and then the stripped Descemet's is taken out. Okay, so now this is the cornea without Descemet's membrane and endothelium, and now, so once you make this, push it like that with the needle. It can be done under air, but ideally it should be done under saline. Okay, and then the air as a tamponade, so it goes and makes the tissue stuck to the. So this is another case. You just see this. So you can make, you need not make a scleral tunnel. You can make a clear canal or at the limbus incision, then two paracentesis on either side, and then under the saline. So now you are extending with, so this is the 26 gauge needle. The tip is blunted against a rough surface. And now under saline, under BSS, so you can start scoring the Descemet's on either side, and then you start stripping that. Now the problem with this, even though you have blunted the tip, still it can go and stick to the stroma. So finally, now the diseased endothelium is removed. So that is a diseased endothelium, and then the pre-placed sutures. This is what I used to do earlier. Now put viscoelastic, preferably a chondroitin sulfate, with the endothelium down on the over the tunnel, and now using the same 26 gauge needle, you can just push under the saline itself. So now you can see the lenticle which has gone in. Now under the lenticle, you are going to push air, so that pushes the whole thing up against corneal stroma. So now it is better to suture the wound so that air doesn't escape with the pre-placed sutures. And now the interface, if at all you want to adjust the graft, okay, or if there are some debris, you don't want anything in the interface, because that can result in inflammation. And so this is the end. It is very simple, not difficult. So now, but still, see, the follow-up is similar to penetrating ketoplasty, but there are complications associated with this also. And then the air that we inject, that I'll come to this little later, their graft can get dislocated. This is one. There can be primary graft failure in case if you are going to damage the endothelium while inserting, with any of the methods. Again, that can, and graft rejection is, can also occur because the endothelium, elevated intraocular pressure, this is what we'll have to take care, especially with so much of air injected in the antechamber, that air can go through the pupil and can cause pupillary block. So you will have to, after 1.5 hours, you better to examine the patient and then burp, remove some amount of air through the side port, so that the pupillary block can be avoided. And of course, there can be infection like in any other case. And then graft can get dislocated for various reasons. In case if at all you are using any viscoelastic substance, which viscoelastic is advised? Suppose patient undergoes cataract surgery along with endothelial keratoplasty, any cohesive viscoelastic substance like sodium hyaluronate can be used so that it comes out very easily. And then there is improper positioning of the donor disc, or there can be delayed endothelial pump, because if the donor endothelium is not healthy, or for whatever reason you have damaged so much that it, and primary graft failure can also result in dislocation. Or in case sometimes, since it is going to be very thin, you don't know which is endothelial side, which is epithelial side, which is stromal side, then the endothelium can go up and stroma can come down. So your endothelium will not function properly. So donor disc again is going to get dislocated. So in a nutshell, it's a very less expensive and very rapid, faster visual recovery and easier surgery, and this is the effective way of correcting endothelial decompensation, provided patient doesn't have the scarring of the anterior surface. Okay, so the results are better than penetrating keratoplasty because there are no sutures here, and then the graft rejection chances are also much less as compared to the penetrating keratoplasty, and the results are of course are reproducible. So thank you very much. Thanks for the patient listening. Thank you.
Thank you so much for that. Was a basic talk for you all PGs. Okay, so whenever you are planning for endothelial keratoplasty, the first step is always manual desing. Once you master that, then automated, then demec. So with this, I think our next session is ready. We are ready with our expert panel and moderator. Thank you so much, Satyamurthy sir, and I hope you both of you will compile and give us the 1, 2, 3. But as I said, you have to mark attendance in all the session, then only you will be considered for best paper of the best case of the session. So with this, will conclude here, and thank you so much. We finished almost 20 case presentation in 1.5 hour with a keynote speaker, all because of you all respected the time. Thank you everyone.